From Microbe TV, this is Infectious Disease Puscast, episode 11, recorded on September 14th, 2022. I'm Daniel Griffin, and joining me today is Sara Dong.
Hello.
Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire.
Puscast is a review of the infectious disease literature for the last 2 weeks that we found interesting or entertaining. Now on to the literature, shall we?
All right. Well, we're going to start with viral, and I want to remind everyone to listen to the TWIV, This Week in Virology, clinical updates for COVID, monkeypox, polio. It just keeps coming. But let me start with the article, Post-Ebola Symptoms 7 Years After Infection. The Natural History of Long Ebola was published in CID. Yes, long Ebola. In this study, symptoms of headache, fatigue, joint pain, muscle pain, hearing loss, visual loss, numbness of hands or feet were longitudinally assessed among participants in the Liberian Ebola survivors cohort study. Well, major post-Ebola virus disease symptoms are common early during convalescence and decline over time along with severity. Even 5 years after acute infection, a majority continue to have symptoms, and for many, these continue to greatly impact their lives. I know we've all kind of forgotten about Ebola, but these findings call for investigations to identify the mechanisms of post-Ebola virus disease sequelae and therapeutic interventions to benefit the thousands of impacted survivors. All right, we're going to move into bacterial. Get your viral stuff over there at TWIV. Perhaps our listeners heard of the mysterious rash of pneumonia cases. It's kind of confusing when I say rash there, but these are pneumonia cases and deaths in Tucumán, Argentina. According to the Pan American Health Organization update, Legionella identified as cause of cluster of pneumonia cases in Tucumán, Argentina. At the time of the identification, there were 11 cases and 4 deaths. If you don't test for Legionella, you're not going to identify it, and you may not treat it appropriately. The article, Frequency of Bystander Exposure to Antibiotics for Enteropathogenic Bacteria Among Young Children in Low-Resource Settings, was published in PNAS. Children in low-resource settings carry enteric pathogens asymptomatically and are frequently treated with antibiotics, resulting in opportunities for pathogens to be exposed to antibiotics when not the target of treatment, the so-called bystander exposure. They find, not surprising, that the more bystander exposures, the more antimicrobial resistance. So keep this in mind when you're throwing around those antibiotics. You're also teaching the bacteria.
I have a great one from CID. Should linezolid replace clindamycin as the adjunctive antimicrobial of choice in Group A streptococcal necrotizing soft tissue infection and toxic shock syndrome? A focused debate. So invasive Group A strep infections like necrotizing soft tissue infection, as it mentioned in the title, and toxic shock have high mortality rates. And so our two authors here took 2 stances. So I'll sort of summarize briefly. Dr. Ryder took what I called the classic clindamycin platform based on relative abundance of data regarding its benefit, including in vitro, in vivo, and clinical studies with reduced mortality, albeit with retrospective data. The other sort of argument here was that when given with penicillin, it seemed that clinda resistance might not actually worsen clinical outcomes in these patients. And so on the other debate stand is Dr. Cortez Penfield, who takes the tantalizing linezolid stance, which focused on clindamycin resistance, which was associated with a greater risk of amputation in one study despite similar mortality, and favorable outcomes despite less studies. The other pitches built into the linezolid, pro-linezolid group is the lower risk of C. diff infection, although whether a short toxin adjuvant course might be irrelevant. You could mention, and then increase MRSA activity, which may in turn help limit the use of Vanc as a third drug for some of these patients. So, a really cool resource. I look forward to more of these in CID in the future. And Daniel, we'll have to think of some topics and try to see if we can get ourselves invited for something controversial.
Oh, so we can have a debate and take sides. It is interesting. Like, so I put in the, great one in this, I was actually on updating this, Sarah, when you were doing it. And I was like, oh, this is so great. And
I immediately went to put it in the document so you wouldn't steal it.
but I mean, I think this is really interesting, like, because we're thinking a lot of times about strep, right? Group A strep, right there in the title. And we have increasing resistance, right? And so, is Clinda doing much? I sort of worry about that. So we're looking at old retrospective data. Is it time to move forward? So I do think this is a great, great one. But this next one, actually, I was a bit worried, Sarah, that you would snag this one before me. But the article, there's actually a couple I was worried you'd jump in on. Treatment with a 3-drug regimen for pulmonary tuberculosis based on rapid molecular detection of isoniazid resistance, a non-inferiority randomized trial, FAST TB, published in OFID. Now, I do not know how many people know that the rationale behind the use of ethambutol in the standard tuberculosis treatment is to prevent the emergence of resistance to rifampicin in case of primary resistance to isoniazid. So a little bit of a pearl there. And why are we using ethambutol? So these investigators evaluated whether early detection of isoniazid resistance using molecular testing would allow the use of an ethambutol-free regimen. So think about that. If you've got that information, if you know it's not isoniazid resistant, maybe you don't have to use that ethambutol. Maybe you don't have to risk people losing their color vision. So these are the results of FAST-TB, a phase 4 French multi-center open label non-inferiority trial that compared 2 strategies. So strategy 1, this is PCR-based detection of isoniazid and rifampicin resistance at baseline using the genotype MTBDR plus version 2.0, followed by ethambutol discontinuation if no resistance was detected. So that's the PCR arm. And then 2, a standard 4-drug combination pending phenotypic drug susceptibility results. Those take a while. Adult patients with smear-positive pulmonary TB were enrolled. The primary endpoint was the proportion of patients with treatment success, defined as a bacteriological or clinical cure at the end of treatment. A non-inferiority margin of 10% was used, and overall 83.7% in the PCR, 82.8 in the 4-drug arm. So, in a setting with low prevalence of primary isoniazid resistance, a 3-drug combination with isoniazid, rifampicin, and pyrazinamide based on rapid detection of isoniazid resistance using molecular testing was non-inferior to starting that recommended old school 4-drug regimen.
Yeah, I did like that paper. My next one, I think, is on a interesting topic that comes up clinically when you have patients with Staph aureus bacteremia. So in diagnostic microbiology and infectious disease, the skip phenomenon in Staphylococcus aureus bacteremia clinical implications. So the skip phenomenon is the presence of intermittent negative blood cultures due to Staph aureus, and this has been seen in adult and pediatric patients. In this paper, it was defined as recurrence of bacteremia after at least 24 hours of negative blood cultures despite antibiotic therapy. So this multi-site retrospective study examined all positive Staph aureus blood cultures in adult patients in 2019, so they had a group of about 500 patients, and found that 5% experienced the skip phenomena after a median of about 4.8 days. And then patients in the skip cohort had overall higher rates of injection drug use, longer bacteremia duration, more likely to have high grade and complicated bacteremia. And there was a trend towards higher risk of in-hospital mortality, although no significant difference at the 90-day relapse or 1-year mortality. there are some limitations. I think there's a lot of variability in how blood cultures are obtained and how we ask for them. So if your patient looks ill and has known prosthetic devices or hardware, I think we tend to be biased towards getting those extra blood cultures. But overall, I really liked this resource and giving a little bit of perspective on what is that time gap in the skip phenomena.
All right. So we have lots of dogma in medicine. I'm looking forward to, being the Dr. House upcoming, being the attending at Columbia. And I love the dogma out there. The article, Relationship Between Antibiotic Agent and Mortality in Patients with Febrile Neutropenia Due to Staphylococcal Bloodstream Infection, a multi-center cohort study, was published in Open Forum Infectious Disease. So methicillin susceptible Staph aureus, MSSA, is a common cause of bloodstream infection in patients with febrile neutropenia. So once we know the pathogen, do we narrow the antibiotics based on the microdata? Is that the right thing to do to provide the best outcome for our patients? That's the dogma, right? Optimize that MSSA bacteremia therapy with cefazolin or nafcillin. So these are the results of a multi-center retrospective cohort study of MSSA BSI in febrile neutropenia. There were 3 treatment groups. So these are your 3 choices. 1, broad spectrum beta lactams, that's piperacillin, that's zosyn, that's cefepime, that's meropenem. 2, narrow spectrum, you just narrow it, cefazolin, oxacillin, nafcillin. Or number 3, combination, you keep going with the broad spectrum, but you just add on that nafcillin or cefazolin. So what were the different mortality? I always say it's always the last answer, but in this case, it's only the last answer if you're trying to get the highest 60-day mortality. So sticking with those broad spectrum beta lactams, 60-day mortality, 16%. Narrow spectrum beta lactams, 26.7. And combination beta lactams, just adding that cefazolin, nafcillin on, 30.9. Now, the combination beta-lactam approach was the worst and statistically significant higher odds for 60-day all-cause mortality compared with just sticking with what you had originally, that broad-spectrum beta-lactam, with an adjusted odds ratio of 3.39, p-value of 0.13. So the difference between staying broad and getting all narrow in the context of what might be a polymicrobial process was not trending in the right direction. So maybe the problem is not the dogma, but rather quoting the right dogma at the right time in the right patient.
This paper is helpful because I feel like that conversation about the combination beta lactams and like why you should or should not do it in certain settings comes up a lot. I feel like I've had that conversation this week. In CID, I pulled a paper called Antibiotic Indications and Appropriateness in the Pediatric Intensive Care Unit, a 10-center point prevalence study. So this multi-center study found that about 58% of children in tertiary PICU, so pediatric ICUs, received antibiotics. And then when reviewed, about a third of those antibiotics were considered inappropriate. And they broke down those typical examples, which generally were prolonged empiric therapy for suspected bacterial infection with or without shock, no clinical evidence of infection, particularly treating for respiratory infections without sort of a clinical piece to it, unnecessarily broad therapy or excessive durations, and then prolonged postoperative prophylaxis. And I don't know that I found this surprising. It was more of just seeing it quantified and across different centers, I think was really interesting, and emphasizes the places that we can help optimize therapy, which sometimes can be right in the beginning as we're de-escalating, but also making sure that we trim down some of these longer durations that happen.
Yeah, and I do worry. There's children here. Cover your eyes. There's inappropriate antibiotics. Don't look. All right. The article, Clinical Features and Treatment Outcomes of Pulmonary Mycobacterium avium intracellular complex with and without co-infections, was published in OFID. So the authors start by making the comment, patients with PMAC, It's a nice acronym there. May have co-infections with multiple potentially pathogenic organisms. Wait, this is sounding a bit like Occam was not a physician, Hickam was. A patient can have as many diagnoses as they please. And here they point out that they often have MAI plus something else. In this study, 73.8% of the pulmonary MAC patients did not have a co-infection, but 26% had at least one co-infection. So a quarter had at least one. Among the patients with co-infection, the majority, 71.6%, had a bacterial co-infection, 31% had aspergillus co-infection, 10% had a mycobacterial, another mycobacterial co-infection. Now, 84%, the co-infection was just monomicrobial. 16%, they had polymicrobial co-infection. So a lot going on.
Got some good mycobacterial papers today. I have another paper that also happens to be from CID, Outcomes of Partial Oral Antibiotic Treatment for Complicated Staph aureus Bacteremia in People Who Inject Drugs. And so this looked at adult patients with a history of injection drug use who, as the title said, have complicated Staph aureus Bacteremia. And I would say, not surprisingly, found that patients who got oral antibiotics after an incomplete IV course did better than those discharged without antibiotics. The success rates were highest when patients got at least 10 days of IV antibiotics after their clearance of bacteremia, which is similar to the POET trial. I think a key part of this study was that there is a outpatient sort of support network for these patients after they leave the hospital. But really, there's no reason to not provide oral antibiotics to someone who is unable to continue with their current IV therapy.
Yeah, no, I think that's critical. This comes up, Dr. Griffin, someone's leaving AMA. I'm like, okay, what can we send them out on? Just because they're leaving AMA, just because they don't want to follow our medical advice, let's not just treat them without proper therapy.
Yeah, exactly.
All right. The article, Short versus Long Course Antibiotic Treatment for Uncomplicated Vancomycin-Resistant Enterococcal Bacteremia, a retrospective multi-center cohort study, was published in CMI. Can you guess? 219 patients were included in the final analysis. Short, so that's median 7 days, and long course, that's a median of 15 days, were compared. 30-day mortality was similar in both groups. Duration of hospitalization, however, was significantly shorter in the short course treatment. Shall I mention they also got less antibiotics, whereas other secondary outcome parameters did not differ between the two groups. Now, I would have thought, Sarah, that you would have snagged this one.
You're lucky I'm on service.
The article, Infectious Disease Consults of Pseudomonas Originosa Bloodstream Infection and Impact on Health Outcomes, was published in OFID. And they show about a 50% mortality reduction with just getting an infectious disease consult for Pseudomonas bacteremia. Perhaps those should be mandatory, just saying.
And our fungal section was looking a little lonely, but we got some papers in just under the deadline here. I selected a clinical microbiology review because those are always wonderful. This one was on Paracoccidiomycosis, current status and future trends. I actually have yet to have a case of paracocci, and so this was a nice review for me. So I decided what I would do is just pull out a couple bullets that were things I learned or things that I was reminded of. So this is a neglected tropical mycosis caused by Paracoccidioides brasiliensis mostly, but there are other species or cryptic species that can cause infection. The first case is described in 1908 from Sao Paulo, Brazil by Adolfo Lutz, but it took a while to classify paracocci as a separate, distinct fungus from coccidioides. So skin lesions are commonly why patients present, but the bug does have the capacity to spread to multiple organs, particularly the lungs, which are the portal of entry, lymphadenopathy, which you can see in some of the images in the paper. And then one that stands out to me is the lesions of the nasal cavity, oropharynx, larynx, which they summarize as the upper aerodigestive tract. And so I read a little bit about, they describe some of the clinical forms, and these are based on some consensus guidance. So regressive, progressive, mixed, residual form. And then just a reminder that amphotericin and azoles have activity for paracocci, as well as trimethoprim sulfa. So another unique thing that Bactrim can treat.
Yeah, I was fortunate to spend a bit of time down there in Peru, so I have seen a bunch of cases of this and the classic under the microscope mariner's wheel. So one of
Yep.
my favorites. All right. The article Comparative Outcomes of Candida auris Bloodstream Infections, a multi-center retrospective case control study published in CID. We recently had a patient in the hospital with this. I'm very glad that they called the other ID doc. Um, I did nudge them. Oh, she has much more experience with this. I don't really like C. auris, but maybe I should like it a little bit more. So 196 patients were included in the final analysis, including 83 cases of candidemia caused by C. auris. After inverse propensity adjustment, C. auris BSI, bloodstream infection, was not associated with increased odds of 30-day mortality or 90-day mortality, but a higher risk for microbiologic recurrence within 60 days of completion of antifungal therapy was observed in the C. auris patients' adjusted odd ratio of 4.461. So maybe I shouldn't dislike this. I shouldn't avoid this as much as I do. But you know what? Michelle Cho, who I work with, she's an expert in this field. So make sure to call her. All right. The article Efficacy and Immunogenicity of R21 Matrix M vaccine against clinical malaria after 2 years follow-up in children in Burkina Faso, a phase 1/2b randomized controlled trial, was published in the Lancet Infectious Diseases. So more on this new malaria vaccine. We've been covering this a little bit on This Week in Parasitism. But in this trial, we are hearing about the impact of a booster after the primary series. Is there a theme here? In this ongoing trial, 409 children returned to receive a booster vaccine after the primary series. Each child received the same vaccination for the booster as they received in the primary series of vaccinations. So we have different levels that they're going to get here. So I'm going to jump to the chase. Vaccine efficacy was 70% in the low dose adjuvant group, 80% in a high dose adjuvant group. In the high dose adjuvant group, vaccine efficacy against multiple episodes of malaria was 78%. And they estimate that 2,285 cases of malaria were averted per 1,000 child years at risk among vaccinated children. Among these participants, at 28 days following their last R21 Matrix M vaccination, titers of malaria-specific anti-NANP antibodies correlated positively with protection against malaria in both the first year of follow-up and the second year. So this is nice. We're actually seeing a correlate of protection. A booster dose of R21 Matrix M at 1 year following the primary 3-dose regimen maintained high efficacy against first and multiple episodes of clinical malaria. Further, the booster vaccine induced antibody concentrations that correlate with vaccine efficacy. So is that going to do it? Or do we need yearly, well-timed booster shots? So we just throw darts at the board, like some people are maybe doing with the COVID boosters, make a pronouncement? Or shall we do the science? The investigators tell us that the trial is ongoing to assess long-term follow-up of these participants and the value of further booster vaccinations. And I would love to have some information here about disease severity. I don't just care about infection. How sick do these kids get? Are we keeping them out of hospital? Are we keeping them from dying of malaria?
Yeah, it's interesting. Speaking of children, I brought a paper from JPIDS, and this is how I approach Leishmaniasis diagnosis and treatment in the United States. And I think whenever there are these sort of how I approach papers, I find that they're always really interesting and helpful. So just as a reminder, I feel like I'm giving some reviews on my selections this week. Leishmaniasis is a vector-borne disease caused by the intracellular protozoa, Leishmania, and a neglected tropical disease. And we see it less in the US, but it's still important for us to recognize in those who are either returning from traveling, military service, those who are immigrants or refugees, and in some areas of the southern US. And so they talk a bit about syndromes and management. And I think one of the takeaways, not too surprisingly, is that treatment options for children are limited because children tend to not be included in trials. So we're extrapolating from adult literature like we basically always do. But some of the newer studies that they've sort of highlighted in this paper focus on how the extrapolation that we're doing is likely leading to underexposure and poor outcomes in children that are being treated for disease. So it's a great paper.
All right. Maybe this is a time to plug. I mean, I think all infectious disease docs should spend a little time overseas, right? It should be part of the training. So when these less common things show up, we've seen them. We've had some experience. So programs down, the Gorgas program down in Peru, Trop Medics over there in Africa. We've got floating doctors in Panama, FIMRIC throughout the world. So lots of opportunities for infectious disease docs to go out there, not only make a difference, but even get some experience. All right, the MMWR Malaria Surveillance United States 2018. Now, the CDC, this is a perfect plug, received reports of 1,823 confirmed malaria cases with onset of symptoms in 2018, including one cryptic case and one case acquired through a bone marrow transplant. The number of cases of malaria diagnosed in the United States and its territories has been increasing since the mid-1970s. Among all cases, P. falciparum accounted for most infections, so 69.8%, followed by P. vivax, 9.5%, P. ovale, 5.2%, and P. malariae, 2.6%. For the first time since 2008, an imported case of P. knowlesi was identified in the United States and its territories. So most patients, 92.6%, had symptom onset less than 90 days after returning to the United States or its territories from a country with malaria transmission. Of the U.S. civilian patients who reported reason for travel, 77% were visiting friends and relatives, the so-called VFRs. Among the 864 U.S. residents with malaria for whom information on chemoprophylaxis use and travel region was known, 95.0% did not adhere to or did not take a CDC-recommended chemoprophylaxis regimen, which means 5% did. So another plug for spending a little time overseas. I have to say, when I spend time in Uganda, we see multiple cases a day. As an infectious disease consultant, you don't want to be so excited that you're seeing malaria that you forget what to do. You want it to be something that you have comfort with. And how do you get that comfort? Go hang out in a malaria endemic place for just a little bit of time. All right, few to finish us off here in the miscellaneous. And again, fighting the wrong enemy, antibacteriophage immunity in phage therapy was published in JID. I am lucky Sara's on service. Yes, this does bring back the days of Aerosmith, or maybe some recent febrile podcasts.
Yep.
But attacking pathogens with one of their natural enemies. And what happens? Our immune system jumps in, just like when the Taliban came to save James Bond in The Living Daylights. All right. Now, this is my favorite for this week. So we're going to finish off with my favorite. So this is the article, Improving Understanding and Utilization of the Antibiogram Among Medical Residents. This was sent to us by one of our listeners, Stephen Cooper. This was published in Antimicrobial Stewardship and Healthcare Epidemiology, though this study sought to investigate the understanding and utilization of the antibiogram among physicians in family medicine, internal medicine, and surgery residency programs at a Midwest academic healthcare institution. And I quote, "The antibiogram is a powerful tool for providers when selecting empiric antibiotic coverage. Its use is recommended by the Infectious Disease Society of America, the Centers for Disease Control and Prevention, and clinical decision support resources to aid in antimicrobial stewardship and patient care." To me, this seems so simple and straightforward. The culture comes back with, let us say, E. coli. So I asked the residents, what antibiotic should we use? One that fails about half the time, or one that works, let us say, greater than 90% of the time? Remember, it's always that last answer. When they start rattling off different options, I ask them, is there some secret place we can look for the answer to which antibiotic works, what percent of the time? And then we discuss antibiograms, the yearly updated answer to this critical question that allows one to actually pick the right antibiotic for your patient with the highest success rate. So for those of our listeners perhaps not familiar with antibiogram, what each hospital healthcare system does, and usually for each particular healthcare setting or hospital. They will look at which different bacteria have been isolated, and they will then publish for our benefit the resistance and susceptibility rates. So let's say you're thinking of treating that E. coli. You might look at your card and say, ooh, if I do Cipro, I'm going to fail 40% of the time. Oh, maybe I shouldn't do that. Ooh, let me reach for augmentin. Ooh, another 40% fail. Oh, maybe I'll pick secret option number C that works 90% of the time. So this is critical. So of course, everyone's using this. Well, for this project, a 9-question survey was developed to determine resident physicians' understanding regarding what an antibiogram is, as well as to assess their past exposure to infectious disease rotations, knowledge of how to access the institutional antibiograms, past use of the antibiogram in patient care, and comfort levels with using antibiograms. They created educational posters with QR code links to the institutional antibiograms and surveyed before and after this very inexpensive intervention. They found that 57% of residents surveyed in 2021 and 89% of residents surveyed after in 2022 reported that they knew what an antibiogram was and were able to describe at least one attribute of it correctly. It's kind of a low bar. The increase of 32% was statistically significant with a p-value of less than 0.001. And not only do they now know what an antibiogram is, but 38%, that's still low, reported using the antibiogram at least once in 2021. And this went up to, are you ready for this? 65% in 2022. So really, a third of the time, they're not looking. Here's the magic answer to getting your patient on the right antibiotic a day earlier. I'm too busy to do that. Significantly more residents with ID training, 86%, could tell you what an antibiogram was, compared to 43% of residents with no ID training. Really? No ID training? Ouch. So just my little push. I'm going to tell a story because it drove me crazy the other day. I get a call. We have this new after-hours antimicrobial stewardship at one of our healthcare systems. We won't mention which one. And so I get the call. Your patient is growing a particular organism. Would you like us to switch to antibiotic V, my favorite antibiotic? And I say, I'm looking at the antibiogram here, and 45% of the isolates are resistant. They said, what? How do you know that? I only have information here for gram negatives. I'm like, oh, please click on that bottom tab, which turns it gram positive. Oh, yeah. So if you're going to do antimicrobial stewardship, do it right. Teach them about the antibiogram.
This is also a signal that we should have more people come rotate with us. So, those in power, get trainees to come hang out with us so we can talk all day about antibiograms. But that will bring us to the end of this Puscast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast. We love to get your questions, comments, and paper suggestions. We may even mention. Send them to puscast@microbe.tv. Consider supporting the science shows of Microbe TV at microbe.tv/contribute.
I'm Sara Dong. You can find me on Twitter at swindong, at Febrile Podcast, or at febrilepodcast.com.
And I am Daniel Griffin, and you can find me at parasiteswithoutborders.com, on Twitter at Daniel Griffin MD, as well as on the other podcasts. This Week in Parasitism, This Week in Virology, clinical updates. As always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye. Thanks for listening. We'll be back in 2 weeks.
Another Puscast is infectious.